Assalamualaikum and a very good evening to all of you present in the Docquity platform. So I am Dr. Mawada Azman. I am from University Kebangsaan Malaysia Medical Centre. I work in the Department of Otorhinolaryngology and Head and Neck Surgery, and today I'll be talking about sore throat and beyond. So I have no disclosures or conflict of interest to tell you all, but this talk has been sponsored by Innova Pharmaceuticals, and I did not receive any monetary or any benefits from this company. So sore throat is a feeling of pain, or some patients describe it as scratchiness or having irritation, and probably an awful sensation at the throat. And this sensation is often worsens when someone swallows. So sometimes when it's so severe, when you're swallowing your own saliva, it feels so painful for the patient. Yeah? And in terms of etiology, we know that viral pathogens are more frequent cause of infective sore throat compared to bacterial pathogens. And in fact, when you look through all the literature, you will find that the majority of infective causes of sore throat is contributed by viral infection. However, if we talk about bacterial infection, the group A beta hemolytic streptococcus, or in short form we call GABHS, is the most common bacterial cause of acute pharyngitis. So this accounts for 15 to 30% of the cases among children, and it is also the only common form of pharyngitis for which antibiotic therapy is indicated. So most of the time we will be able to treat patients presenting with infective form of sore throat with conservative management. So it can be a simple pharyngitis, it can be tonsillitis, and so it can occur at any part of the throat. So it can occur at the level of the oropharynx, be it here at the soft palate, or it can occur here at the tonsil region. So patients will present with the common complaint of a sore throat. So in most cases, we treat them conservatively, but if we suspect the patient has group A beta hemolytic streptococcus, we will need to start antibiotics on these patients. So these are the etiologies of patients presenting with sore throat. Yeah. So main etiology is viral in origin. So rhinovirus constitute the most of the viruses that causes sore throat, and then followed by coronavirus, adenovirus, herpes virus, parainfluenza virus, Coxsackie A, EBV, CMV, and HIV. These data were taken from the Clinical Practice Guidelines report on sore throat, on management of sore throat, which was quite outdated, taken in April 2003. We've not got any revisions yet, so we don't sure what is the epidemiology in terms of the etiology of sore throat among viral organisms, particularly after COVID-19. So this may change after the pandemic. So if you talk about bacterial infection, the most commonest bacterial cause of a patient presenting with sore throat is Streptococcus group A, which accounts to up to 30% of the cases. Then we've got other types of Streptococcus, the group C Streptococcus, about 5%, Neisseria gonorrhoeae, less than 1%, Corynebacterium diphtheria. So this causes a more severe form of sore throat, in which the patient will present with severe dysphagia, severe odynophagia, and very bad dehydration. So in diphtheria sore throat, the patient will present with a whitish lesion, like a whitish plaque on the tonsils, on the pharynx itself, and it may cause severe respiratory embarrassment. Other bacterial organisms would include Arcanobacterium hemolyticus, Chlamydia pneumonia, as well as Mycoplasma pneumonia. So we've talked about this, and the bacterial infection that we want to pick up from the patients presenting presenting with sore throat is the group A beta hemolytic streptococcus. So I've looked through the literature and find what are the clinical predictors, what clinical predictors can be used to successfully differentiate between group A beta hemolytic streptococcus pharyngitis and other types of pharyngitis. I mean, the ones that we can treat conservatively. So unfortunately, the only sign that can discriminate group A beta hemolytic streptococcus and viral cause is the scarlet fever type rash. So the scarlet fever type rash is a very typical rash that occurs after 48 hours of the initial onset of the symptoms, be it fever and sore throat. After 48 hours, the patient will present with these typical rashes that will occur at the patient's body, upper limb, and also the patient will present with this typical strawberry-like tongue, in which the papilla of the tongue will appear more prominent. And after 1 week, the scarlet fever type rash will resolve spontaneously and it will peel off. So this is a typical progression of the scarlet rash. We know that group A beta hemolytic streptococcus pharyngitis is rare among children less than 4 years old. So what we are worried of is they cause a lot of complications. So these complications can be divided into non-suppurative and suppurative types of complications. The non-suppurative type of complication is the acute rheumatic fever, where they will present with arrhythmias, sometimes they present with heart failure, and they can also have other non-suppurative complications like post-streptococcal glomerulonephritis, where the patient will present with symptoms of nephrotic syndrome. They present with puffiness, their ankles will be swollen, there will be a lot of fluid retention in their body. Some complications are also suppurative in nature, where the patient can present with peritonsillar abscess, in which there will be an abscess collection at the superior aspect of the tonsils, or perhaps this abscess collection can go to the deep spaces of the neck, including the parapharyngeal and the retropharyngeal spaces. So in these situations, suppurative complications, the clinical presentation may be quite bad and the patient would require high dependency care or even surgical treatment. So there is a subgroup of patients who are more susceptible to develop complications from group A beta hemolytic streptococcus pharyngitis, and these are patients who are immunosuppressed and patients with history or positive family history of acute rheumatic fever. So we need to be watching out for these immunosuppressed patients, or if the patient him or herself has history of acute rheumatic fever, or there are family members with a positive family history of acute rheumatic fever. And sometimes it's even justifiable for us to treat family members of patients who are immunosuppressed, because we know that if the immunosuppressed family member contracts group A beta hemolytic streptococcus from that particular patient, the complications would be disastrous. Right, so these are some of the several severe forms of sore throat. And so we've talked about peritonsillar abscess, in which there will be a collection of abscess here at the superior pole of the tonsils. So this is an example of a patient with diphtheria. I've talked about this. You can see that there is a whitish plaque-like lesion located here at the tonsils. So these plaque-like lesions can cause upper airway obstruction, and sometimes these infection can spread inferiorly to involve the tonsil, the epiglottis, as you can see here, causing acute epiglottitis or acute laryngotracheal bronchitis. Deep neck space abscesses like retropharyngeal abscess and parapharyngeal abscess, they present in a patient who is toxic. Sometimes they have problems with their hemodynamic status, they are febrile, and they need to undergo emergency incision and drainage. And infections in patients with deep neck space abscess is difficult to control. They need to go for repeated wound debridement, and they generally present with severe odynophagia and typical bulging, which is seen either at the lateral pharyngeal wall or the posterior pharyngeal wall. Okay. So in the subacute or chronic form of sore throat, certain diseases might come into our minds, like allergic rhinitis, atrophic rhinitis, irritants causing pharyngitis, muscle strains in certain population and certain age group, and certain occupations like teachers. They may have muscle tension dysphonia causing sore throat and odynophagia. And then patients with laryngopharyngeal reflux, reflux of acid or non-acidic contents from the stomach that goes to the larynx, causing sore throat. HIV infection, or even tumors. So these are some of the causes that we see if the patient presents with subacute forms or recurrent sore throat. So the management of sore throat includes several prongs or several angles. The first angle we're looking at is the symptomatic treatment of a patient presenting with sore throat. The second would be to consider antibiotic therapy for patients with group A beta hemolytic streptococcus pharyngitis. And last but not least, we may want to consider surgical treatment. And some patients present chronically, they have chronic tonsillitis, they would require tonsillectomy, or if the patient develops complications like deep neck space abscesses, they may require incision and drainage. And of course, the first prong, the first corner of the cornerstone of the management would be symptomatic treatment, is because the patients present with those symptoms and they expect these symptoms to be resolved within 1 or 2 days. So 1 in 2 sore throat sufferers seek a physician's consultation, and what they want is rapid pain and symptom relief. So they want to go back to their usual self, go back to work, go back to their studies, and hopefully the pain will resolve faster. So this was taken from the clinical practice guidelines published for the management of the sore throat back in 2003. So back then they used the McIsaac score to see whether you would need to initiate antibiotic or obtain throat swabs, but I've talked about this. Perhaps using the scarlet rash kind of like signs will be more useful. Now, you look at the clinical feature of the patient. Does the patient has associated nasal symptoms, for example, rhinitis, any significant eye symptoms, conjunctivitis, or other symptoms like diarrhea or ulcers? So the presence of these symptoms, symptoms from many systems, would suggest that viral etiology is more likely, and you can start the patient on symptomatic treatment. Okay, whereas if you think that there is high likelihood that the patient has a bacterial form of infection, back then the Ministry of Health suggested if the fever is more than 38 degrees Celsius, there was no cough, you can see tonsillar exudates, there's tender cervical lymphadenopathies, and the age is less than 15 years old, and the patient score 2 to 3 or 4 or more, it is justifiable for us to get a throat swab for confirmatory, and then after that to initiate antibiotic therapy. So after failing antibiotic therapy of 48 hours, so we have to consider perhaps it's not really a bacterial infection and it is a viral infection, and maybe you want to consider whether the patient developed any complications. Okay, so apart from systemic use of analgesics and non-steroidal anti-inflammatory agents, the use of throat lozenges or gargles is perhaps one of the management avenue that is used widely in the treatment of sore throat. This is because they are using agents which is very targeted, locally acting at the pharynx itself. So therefore the side effect profiles is so low, and you don't get a lot of allergies associated with the use of throat lozenges or even gargles. Other treatment options that can be used for a patient presenting with sore throat is perhaps we can give steroids in select cases. That we've came across some patients with very bad odynophagia, and sometimes they develop acute supraglottitis that needs to be treated with steroids because of severe edema. Vaccination also plays an integral role in patients presenting with sore throat. This is because it is useful to prevent these infections, especially if the patient is living in seasonal areas. So the second cornerstone of management is antibiotic therapy for group A beta hemolytic streptococcus pharyngitis. So antibiotic therapy for group A beta hemolytic streptococcus pharyngitis should not be used routinely to secure symptomatic relief of sore throat. So bear this in mind. If you have a patient presenting with sore throat, please do not use antibiotics routinely. So you have to select your patients. You have to think whether is this most likely viral, most likely bacterial, and weigh the risk of giving antibiotics to your patients, because we don't want emergence of resistant strain of organisms. So far I've been seeing this. Of course, these past few decades, I mean, even GPs are giving amoxicillin and clavulanic acid for patients presenting with simple sore throat. So that practice itself can promote resistance. So start with simple antibiotics first. Penicillin based should do great. Even for us in the tertiary center, we still use intravenous penicillin at high doses to treat peritonsillar abscess. It's still working. You just have to get the doses right. Yeah? So when to give patients antibiotics in a patient presenting with pharyngitis, of course, when you suspect bacterial infection of group A beta hemolytic streptococcus infection, and the objective of this antibiotic therapy is to prevent acute rheumatic fever. So as to speak, if you have a patient with history of acute rheumatic fever, do give antibiotic. And even if you have a patient who has family members who are immunocompromised, give them antibiotic, because you want to prevent acute rheumatic fever. You want to prevent acute suppurative complications. Some patients who are immunosuppressed, they cannot afford to develop all these severe suppurative complications. And the third objective is to decrease infectivity or prevent transmission and shorten the clinical course of the disease. So severe symptoms, you want to shorten the clinical course, and perhaps it's justifiable to give antibiotics. Prevent transmission, I was talking about patients with family members who are immunosuppressed, and you want to prevent transmission occurring within the family itself. So those are the goals. So what antibiotic therapy would you give for patients with suspected group A beta hemolytic streptococcus pharyngitis? I think penicillin remains the drug of choice because it has proven efficacy. It has got narrow spectrum, safe, and it's low cost. And if you choose to give oral therapy, give a full 10 days course to ensure that you will get maximum rate of eradication of the infection from the pharynx. So in patients who are allergic to penicillin, you might want to consider giving erythromycin. And if, let's say, the patient is allergic to both penicillin and erythromycin, clindamycin is an option for these patients. Right? Surgical treatment like tonsillectomy is indicated for select cases. For example, in cases of chronic tonsillitis, recurrent tonsillitis, and perhaps IND for parapharyngeal abscess and also retropharyngeal abscess. Right, so we'll talk about benzidamine hydrochloride. So benzidamine hydrochloride has 3 actions. Yeah, you've got anti-inflammatory action, analgesic action, as well as anesthetic effects, in which all these 3 effects and 3 actions is provided locally. It's very important. They do not have a lot of systemic side effects because these drugs are administered locally at the level of the pharynx. So benzidamine blocks inflammation by inhibition of the products of pro-inflammatory cytokines, and these cytokines including tumor necrosis factor alpha and interleukin-1 beta. These are major drivers of inflammation. This is the thing that causes the patient to have the pain, and it has little effect on anti-inflammatory cytokines, which is good, and therefore it blocks inflammation really well at the pharynx. So benzodiazepine elicits supportive anti-inflammatory activity through cell membrane stabilization, and also it reduces capillary vasodilatation and edema, and it also blocks the release of pro-inflammatory substances. So we have very effective blockade of inflammatory cascade occurring at the level of the pharynx. So benzodiazepine is ideal for topical applications, and therefore we use it widely for the management of acute pharyngitis as well as tonsillitis. So because you are giving specific concentration at a very focused area at the inflammatory tissue, so it reaches the targeted tissue very well, and we know that it reduces neutrophil aggregation, which is paramount in inflammation, and it inhibits the production of pain and inflammatory mediators. We've talked about these mediators, interleukin 1 as well as tumor necrosis factor alpha, and we also know that it basically blocks vasodilation, and therefore you will get less edema, less erythema on the patient side, and it is inactive in normal tissue, so it doesn't affect normal tissue. So the local anesthetic activity of the benzodiazepine is given by the presence of these hydrophobic aromatic ring and hydrophilic quaternary amine, or we call this intermediate chain amide linkage, that cause local anesthetic effect, which is given at the pharynx. Okay. So comparison of benzodiazepine and other non-steroidal anti-inflammatory drugs, which is given systemically. So benzodiazepine is a base structure, it is non-acidic, it is friendly to the stomach, it doesn't cause any gastritis or stomach irritation or any reflux because it is given locally. It gives membrane stabilizing effect. We've talked about this earlier, whereby NSAIDs doesn't give this membrane stabilizing effect. Benzodiazepine possess local anesthetic properties, while non-steroidal anti-inflammatory drugs has no reported anesthetic effect. So benzodiazepine has poor protein binding, therefore it is not systemically absorbed, whereby non-steroidal anti-inflammatory drugs has high protein binding, and it has systemic side effect. So we'll go through a few clinical papers on the clinical effect of benzodiazepine hydrochloride. So the first is, I think this was a landmark paper when this drug was first introduced. This is back in 1985, whereby the use of benzodiazepine hydrochloride was described in a double-blind study for patients presenting with acute sore throat. So they've recruited 15 physicians, and they've recruited 44 patients presenting with sore throat. 21 were randomized into the benzodiazepine group, and 23 were randomized into the placebo solution. So they wanted to test the acute effects of giving benzodiazepine hydrochloride to the patients. So they've asked the patient to use 15 ml of the test solution. They were required to gargle every 2 to 3 hours. So this is not the spray solution, this is the gargle formulation, in which the patient is asked to gargle this to the back of the throat, and they were asked to use this every 2 to 3 hours for at least 24 hours. So benzodiazepine gargles can be used 2 to 3 hours once, because they don't have systemic toxicity. You can even finish one whole bottle for one day and can use it safely. And the patients were not prescribed on any systemic analgesics or anesthetic drugs. So these are sole interventions or single modality treatment using benzodiazepine or even placebo. So after 24 hours, the physicians examine the pharynx for signs of inflammation like hyperemia and edema, and the patients rated their symptomatic relief of pain and dysphagia. So this is what happened to the cohort of patients. So you can see that patients who were treated with benzodiazepine had an improvement scale of more improvement compared to patients who are treated with placebo. So there were more patients in the benzodiazepine arm who had an improvement scale of 3 or more in terms of their pain and dysphagia, compared to the placebo group, and these clinical differences are statistically significant. So what about the appearance of the pharynx? So the physicians rated that the presence of hyperemia and edema at 24 hours after administration was also less among patients who were treated with benzidamine compared to patients who were treated with placebo, and these differences were statistically significant. Okay. The next study was a comparative study of benzidamine hydrochloride. This is given as a spray solution, and they compared this with a placebo as analgesics following tonsillectomy. So this was a study among children aged 4 to 11 years old, and they managed to recruit about 56 children. So the objective of the study was to assess the clinical effectiveness of the use of benzidamine hydrochloride throat spray in the prophylactic reduction of post-operative pain among children in the period immediately following tonsillectomy. So again, the participants were asked to administer the benzidamine throat spray to the operative sites, meaning they are aiming it towards the tonsil bed, and they are using this 30 minutes before each meal in the 2 days after the operation. So their outcome measures were sore throat, otalgia, dysphagia, and appearance of the tonsil bed. So here you can see that among the patients who are treated, this one they have they measure the outcome measures at day 1 and day 2 post-surgery. So you can see at day 1 post-surgery, there's a lot of patients presenting with severe sore throat, both in the benzidamine group as well as in the placebo group. But you can see here, after 1 day of use of benzidamine throat spray, the number of patients with persistent sore throat has improved at even day 2. Similar, and these differences are statistically significant. And if you can see in terms of dysphagia also, significant numbers of patients with reduction of dysphagia in the benzidamine group, which is more compared to the placebo group, and the differences are statistically significant. The third study is regarding the clinical effectiveness of the use of benzidamine hydrochloride versus placebo in patients with aphthous ulcer. And this was a double-blind crossover study in which they had patients who were randomized into the benzidamine group and then the placebo, and after a washout period of about 2 weeks, the patients were switched to a different group. So you can see here that patients who are using the benzidamine had less pain score and also had more pain relief compared to patients treated with placebo, and these differences were statistically significant. So benzidamine hydrochloride is useful for treatment of aphthous ulcer. And 61% of the subjects reported at least 50% improvement in their pain relief after the usage of benzidamine hydrochloride mouth rinse, as compared to only 22% after using the placebo. And these differences were statistically significant. So I would like to conclude by saying that when sore throats are so painful, relief begins with your expertise. So as those practicing in the primary care clinic, so you have to assess your patients well, decide whether it is a viral or bacterial in origin, and then try to judiciously use antibiotics and consider local treatment like benzidamine hydrochloride to treat your patients. With that, I would like to thank you.